If metabolism questions feel impossible, usually it's because you're trying to memorize pathways instead of recognizing consequences. In this video, we're going to cover purine and pyrimidine disorders, not by redrawing biochemical pathways, but by focusing on what the boards actually test. For every metabolism questions, boards care about three things: what's missing, what builds up, and what the buildup does clinically. If you can answer those three questions, you don't need to memorize the pathway. Before we jump into specific disorders, let's ground this in one simple question. First, what even are purines and pyrimidines? At the most basic level, purines and pyrimidines are nitrogenous bases. They are not proteins, they are not amino acids. They are components of nucleotides, which are the building blocks of DNA and RNA. Think back to biochemistry. At the highest level, not too far back, when you build DNA and RNA, you need nitrogenous bases. You need adenine and guanine, which are purines, those double-ringed nitrogenous bases, and you need pyrimidines, cytosine, thymine, and uracil, the single-ring nitrogenous bases. With a sugar and phosphate added, those purines and pyrimidines become nucleotides. Nucleotides make up DNA and DNA and RNA are essential for cell division and function. This is why the boards care. Why the distinction matters on the board, knowing whether the disorder involves purines or pyrimidines, it tells you which system is likely to fail. Purine disorders are most likely to affect the brain, the immune system, and uric acid balance. Pyrimidine disorders tend to impair your DNA synthesis in your rapidly dividing cells. That's especially your bone marrow. This difference explains the clinical patterns you see. Now, let's apply that framework. Lesch-Nyhan syndrome, which is a purine salvage defect. What is missing is HGPRT, an enzyme that is needed to recycle purines. What builds up? Well, the purines aren't salvaged, so more purines are broken down and uric acid levels rise. What that causes clinically is hyperuricemia, which means gout and kidney stones. There's also neurologic dysfunction. Self-injurious behavior is the classic board clue here. So if you see a young boy, severe neurologic symptoms, self-mutilation, gout or kidney stones, that is Lesch-Nyhan. One more pearl for you, that one is also X-linked recessive. This fits the purine theme: brain involvement, uric acid problems. Adenosine deaminase deficiency. This is a purine breakdown defect. So we're going to talk immunology here. What is missing? Adenosine deaminase. This is needed to break down your purines. What builds up? The toxic purine metabolites, especially in your lymphocytes. What that is going to cause clinically is lymphocyte death, impaired T cell and B cell development, and severe combined immunodeficiency, or SCID. Adenosine deaminase deficiency is a classic metabolic cause of SCID. Boards may not name the enzyme. Instead, they will describe a baby that has recurrent infections, failure to thrive, and severe lymphopenia, as well as an absent thymic shadow. If you see immune failure in an infant and you're in a metabolism question, think ADA deficiency causing SCID. Again, this is a purine disorder, so rapidly dividing immune cells are hit hard. Now, adenosine deaminase deficiency is a classic metabolic cause of SCID, but it's not the only one. Boards also commonly test IL-2 receptor gamma chain mutations, which are the most common cause of SCID overall, and defects like RAG deficiencies. You don't need to memorize every gene, just recognize whether the problem is metabolic, signaling related, or due to a failed receptor formation. A quick purine tie-in is gout and the treatment. This also is going to explain why purine metabolism is closely tied to gout. Purines are ultimately broken down into uric acid. That's why medications like allopurinol work. They inhibit xanthine oxidase and then reduce uric acid production. Let's move to orotic aciduria, a pyrimidine synthesis defect. Okay, we're switching over to pyrimidines here. What is missing? UMP synthase, which is an enzyme in de novo pyrimidine synthesis. What builds up? Orotic acid. What that causes clinically: impaired DNA synthesis, megaloblastic anemia, failure to thrive. Rapidly dividing cells can't make DNA properly. Now I want you to notice ammonia. Ammonia is one of the most helpful lab values on boards for separating pyrimidine disorders from urea cycle defects. In orotic aciduria, we have elevated orotic acid and normal ammonia. Urea cycle defects like OTC deficiency are going to have elevated orotic acid and high ammonia. Normal ammonia points you towards a pyrimidine synthesis problem, not a urea cycle disorder. That single lab value can save you a ton of confusion. So let's put it all together with the board level framework. Purine disorders: neurologic dysfunction, immune failure, gout, and kidney stones. Pyrimidine disorders: impaired DNA synthesis, megaloblastic anemia, growth failure. When you feel stuck, I just want you to pause and ask, what is building up and which system is suffering? That question is usually going to lead you to the right answer. Remember that metabolism questions are not pathway questions. They are cause and effect questions. So if you know what's missing, what builds up, And what that buildup does clinically, you can answer these questions. And you don't have to memorize every enzyme. This same pattern-based thinking shows up again and again in metabolism. Boards reward pattern recognition, not memorization. See the pattern, choose the answer. Let's try this on a case. A 3-month-old infant comes into clinic for poor feeding and failure to thrive. Parents report frequent vomiting and increasing lethargy. On physical, the infant appears pale and hypotonic. Labs show a macrocytic anemia. Serum ammonia is within normal limits. Urinalysis shows elevated levels of orotic acid. Which of the following is the most likely underlying defect in this patient? Adenosine deaminase deficiency, carbamoyl phosphate synthetase 1 deficiency, dihydroorotate dehydrogenase deficiency, UMP synthase deficiency, or ornithine transcarbamylase deficiency. This age is still going to make me think about inborn errors of metabolism. Yes, more severe cases will be in the first few days in their presentation, but still keep these on your differential into the first several months. On exam, this infant is pale and hypotonic, and we have a macrocytic anemia. That already tells me this is not just a urea cycle question. The anemia is the important clue. Now let's look at our lab finding, that elevated orotic acid in the urine. Whenever you see this, you need to pause and ask one critical question. What is the ammonia? In this case, ammonia is normal, and that distinction is everything. Elevated orotic acid with normal ammonia points away from a urea cycle disorder and toward a problem with our pyrimidine synthesis. Specifically, this is suggesting a defect in converting orotic acid into UMP. So now we put the pieces together. Infant, failure to thrive, macrocytic anemia, elevated orotic acid, and normal ammonia. That pattern fits orotic aciduria caused by a deficiency of UMP synthase. The key board takeaway here is that not all orotic acid problems are urea cycle disorders. Ammonia tells you which pathway you're in. Normal ammonia plus orotic acid equals pyrimidine synthesis defect. Let's work on eliminating all of these answer choices, though, one by one. Choice A is adenosine deaminase deficiency. That's a purine metabolism disorder that presents with severe combined immunodeficiency, so things like recurrent infections and lymphopenia. This patient's primary issue is anemia and orotic acid, not immunodeficiency, so it doesn't fit. The next choice, choice B, is a carbamoyl phosphate synthetase 1 deficiency, which is a urea cycle disorder. Urea cycle defects cause hyperammonemia, and we're told explicitly this patient's ammonia is normal, and so that's going to allow us to eliminate this choice. Choice C is dihydroorotate dehydrogenase deficiency. While this enzyme is involved in pyrimidine synthesis, it does not produce the classic board pattern of elevated orotic acid with macrocytic anemia. So this is not the best answer for this presentation. Choice D, we have UMP synthase deficiency, which fits perfectly. A defect in the UMP synthase prevents conversion of orotic acid into UMP, leading to elevated orotic acid in the urine, macrocytic anemia, and failure to thrive. All normal ammonia levels here. Choice E is our ornithine transcarbamylase deficiency, which is another urea cycle disorder, and that would have hyperammonemia, and in many cases elevated orotic acid. But since we don't have ammonia that is high, this is not the right choice. So I want you to remember, if orotic acid is high, but ammonia is normal, think pyrimidine synthesis, not the urea cycle. Here's another case. A 6-month-old infant is evaluated for recurrent infections and poor weight gain. The parents report frequent respiratory and gastrointestinal infections since birth. Physical exam reveals oral thrush and generalized lymphopenia. Laboratory studies show severe lymphopenia affecting both T and B cells. Serum uric acid levels are low. Which of the following enzymatic deficiencies is the most likely cause of this patient's condition? Hypoxanthine guanine phosphoribosyl transferase deficiency, adenosine deaminase deficiency, carbamoyl phosphate synthetase 1 deficiency, UMP synthase deficiency, xanthine oxidase deficiency. Let's walk through the case a little more. This is a 6-month-old infant with recurrent infections, poor weight gain, thrush, lymphopenia. We have both T and B cells impacted. That constellation should immediately raise your concern for SCID, severe combined immunodeficiency. Once I think SCID, I ask the next question, what's the underlying mechanism? In this case, the lab clue we are given is low uric acid levels. That's a subtle one, but it is high yield. Low uric acid tells me there's a problem in purine metabolism, specifically in our purine breakdown. One of the most classically tested purine disorders is adenosine deaminase deficiency. In ADA deficiency, our toxic purine metabolites accumulate and are very harmful, especially to our lymphocytes. That leads to a very profound T cell and B cell dysfunction, which is explaining our recurrent infections, thrush, and the lymphopenia. So if we put it all together, infant with SCID features, low uric acid, and a purine metabolism defect points directly to ADA deficiency. The key idea here is that purine metabolism disorders don't just cause biochemical abnormalities, they can present as immunodeficiency, and ADA deficiency is a classic metabolic cause of SCID. Now let's eliminate the answer choices for this purine case. Choice A is hypoxanthine guanine phosphorybosyl transferase deficiency. This causes Lesch-Nyhan syndrome. That disorder presents with hyperuricemia, self-injurious behavior, and neurologic symptoms, not SCID. This patient has low uric acid and recurrent infections, so not correct. Choice B, ADA deficiency. We've already talked about why this fits exactly. Choice C, carbamoyl phosphate synthetase 1 deficiency is a urea cycle disorder. We would have hyperammonemia here and neurologic symptoms, not isolated immunodeficiency, so we can eliminate this one. Choice D, UMP synthase deficiency, which causes orotic aciduria and macrocytic anemia. No anemia, no elevated orotic acid, doesn't fit. And then choice E, xanthine oxidase deficiency. This does affect purine breakdown, but does not cause SCID. It can alter your uric acid levels, but it would not explain the profound lymphopenia and recurrent infections. So when you eliminate all these choices that don't explain SCID, the correct answer is ADA deficiency. Our one-line board takeaway here, if you see SCID plus a purine metabolism clue, think ADA deficiency. Also, I want you to remember that not all SCID is caused by ADA deficiency. We'll go into more ways to identify SCID and its many causes in a dedicated video.